So let's just clear up some information for the end of the semester. So remember, you still have those case study presentations coming up. I think it's either right before Thanksgiving or right after. I can't remember.
The first one is November 20th, and then or are they all that day? No, and then it says the second one is December 4th.
Okay,
so do we know when we're going, or do you know yet?
We could decide now if we want. I mean, we're missing Nick and Kiara, but some people like to get things out of the way. Don't have to worry about it over Thanksgiving break. I would need at least 5 to 7 for the first day. Texting myself.
Wait, when is it?
November 20th.
November 20th.
Yeah.
Right. Yeah, and then the 4th is the same day our New Year's Eve.
Oh, yeah.
Okay. Alright, so I got Lily, Jenny, Rachel, Melody. Alright, that's 5 slots. So if anybody still wants to volunteer between now and then, I could give maybe 1 or 2 more slots that day, but then the other half of the class will go after. What day is that again, Rachel?
That's November 20th. I think I still need to do it.
Alright. So here's the list of your pathologies that you need to present on. Remember, about 5 minutes per pathology. We only have 3 pathologies, and you have an example that I put up there. Remember, if you want to talk about patient prep, have that just on one slide. You don't have to do it for each case. That's fine. Positioning is going to be a little different. It's not all just the brain, so you can't just put one slide for all of your pathologies, because it might be the C-spine, it might be like a wrist, so you're going to have to change that slide, and then the centering slide is going to have to change up too. So a little different from last semester, but keep it quick. 15 minutes, because we know we kind of ran over last time, so I want to try and get all the presentations during the class period done.
So what is the first day for presentation? November 20th.
November 20th.
And the other one was it December 4th?
December 4th, yeah.
December 4th. So as we get back, kind of the last week right before finals. So if you get a chance, get it knocked out of the way. Also, another reminder, make sure you are starting to complete your simulator book. So all the documents are on Canvas, so just download them. And if you want, the best way for me to grade it is just put a text box into each one, save it, and then upload it onto Canvas. Remember, you guys can divide this up. If you guys want to do, I'll do lab 9, you guys work together, everybody send them in, that's fine, but just make sure it gets done. It's just an assignment. I want you guys to knock it out. And this will be the last time we have the simulator book. It's not continuing on till next semester. Right? So I think that pretty much is it. All right, so this is the last unit in procedures. So we'll cover this. You do presentations. We'll do a final cumulative exam, and you're out of here for procedures. So everybody seems to be doing good. Nothing's really tripping you up.
Will you be able to open them so we can see like the right and wrong answers and stuff?
Yeah. Did I not do it for procedures?
No. No.
Just physics?
None of them.
None of them open?
None.
I said it to. Let's see. See, it says here, let students see correct answers by October 16th, so it should be able to allow you to see it.
It didn't let it say that it wasn't available.
Yeah.
Wasn't available. Maybe I need to available till.
Oh, it cuts it off.
Well, no,
That's
that's
the
when it's
text.
just open.
Yeah.
So you guys are looking at it under respondents lockdown too, right? All right. Try it again today, just in case, and I'll try and mess with it and see. But I thought I changed them all so that you could see. But all right. All right. So today we're going over procedures of the neck, brachial, and lumbar plexus. So soft tissue neck, MRA of the neck, so carotids, vertebral arteries, and then our brachial and lumbar plexus. Brachial plexus is kind of an ongoing discussion within Emory. They've been revamping the protocol. They want to make sure that these are getting done on 3 Tesla magnets. So it's been a topic of discussion. Our MSK doctor, Dr. Singler, is the only one that reads them. So make sure if you guys get a brachial plexus, see them as, who's rotated 3EP12? Have you done a brachial plexus?
They don't really know what they're doing, I feel like, too much with it.
Yeah.
They want, like, students to like,
Yeah.
It's the same way at Hawk. They got some occasionally, but they kept having to call Dr. Singer to figure out what they were doing.
Yeah, and we'll talk about that when I go over the protocol, because there is a lot of interaction. It's like, well, and then you have to raise and lower the arms, things like that. And calling Dr. Singlers to kind of verify, all right, do you have enough images? Are you able to see what you need to see? Type thing. So that's why it is kind of one of those, it's probably the hardest exam right now in the system of trying to get what the doctor really needs to see. All right, so the main things for the registry that you really need to know are the arteries of the neck. So I think we talked about this last time briefly when we were talking about the blood flow through the heart and up through the aortic arch. But we have our blood flow coming from our left ventricle and it goes into our aortic arch, and the first vessel we interact is our brachiocephalic artery. Our brachiocephalic artery splits into our right common carotid artery and our right subclavian artery. From there we have our common carotid that branches off from internal and external. And then our vertebral arteries are posterior, and they come off the subclavian arteries, and that goes into the basilar artery. They converge to the basilar artery, and that is the posterior circle of Willis once it gets up into the head. So make sure you know all the arteries, be able to label these, and be able to label them at different views. So I have a good YouTube lecture here if you want to just copy and paste the link, but the guy goes over all the vessels as he rotates it around. So this is a good video to watch just for your labeling purposes. So, because you're not on the registry, you're going to not get this perfect coronal view all the time. They might rotate it obliquely. So know how to do that. And it's also good for when you're cutting things out and you're segmenting, like Tiffany says, with your nipped image, so that you know which vessels you do not want to cut out by accident. But you always leave your aortic arch, your subclavian arteries, your common and vertebral arteries when you're doing your nipping. Has anybody done any nipping of the carotids yet? Usually you spin the entire carotids, and then you do your common carotids, and then you also segment out your vertebrals. So here's a good way to practice your labeling in your anatomy. Here's a good slide. Also know your brachial plexus anatomy. The main thing with your brachial plexus anatomy is that there are 8 nerve roots within the cervical spine. And you think, well, there's only 7 cervical vertebrae, but you actually have a nerve root between C7 and T1 that is our corresponding C8 nerve root. So you can see here they come from each vertebral body between the pedicles, and then they converge where all those nerves start to bundle right at the apex of the lung here, and then they go all the way out to the shoulder. So if you guys have ever had a patient where they say they have any type of numbness or pain going down their arm, that could be because of a herniated disc or some kind of impingement on that nerve, either near the vertebral body in that spinal canal, or if there is like maybe some kind of thoracic outlet syndrome where all those nerves and vessels converge. Sometimes it's narrowed and it causes a compression of those nerves. That's called thoracic outlet syndrome. Or there could be like some kind of tumor on the nerve sheath that's causing that numbness and tingling in the arms. So a lot of times you're thinking, why am I doing a C-spine MRI or a brachial plexus if they have arm pain? But it's really those nerves coming from, that originate from the spinal canal. And then you have your lumbar sacral plexus. And what's the main diagnosis here? What's the main one where you get leg pain, the radiating leg pain? Sciatica. So sciatica is the big one here, where impingement on that sciatic nerve that runs down the leg. So these are long procedures because they're the fascia or the soft tissue neck is usually with and without contrast. The quickest one is the MRA of the neck because we know this is a contrast enhanced image because we want to image very rapidly to reduce the artifact from the chest and the breathing from the trachea and the esophagus, things like that. So that's a real quick image, but then your brachial plexus and your lumbar plexus, those scans can take a long time too. So make sure to overestimate your time, 45 to 60 minutes at least. Lumbar plexus, you can go feet first. Brachial, you have to attach not only the posterior coils, but the anterior coils. And then if it's a neck, soft tissue neck, sometimes you have to also hook on the brain coil too, because you need to get basically from the frontal sinuses all the way down to your aortic arch. So here are some indications for our soft tissue neck. Once again, it's mostly contrast enhanced, so we're looking for infections, malignancies, any type of tumors with the thyroid or the pharynx, nasopharynx, parotid gland, things like that. Another one would be vocal cord paralysis. Remember, you have two vocal cords that open and close when you're talking. Sometimes a vocal cord, the flap doesn't open or it doesn't close appropriately, and it can cause the patient to not be able to adequately talk. So these are reasons for our soft tissue neck. Make sure you're attaching all the coils, have them all plugged in appropriately. Get the cushions under the leg because this is a long exam, so you don't too much pressure on their back throughout the procedure. Sometimes if you don't have a good enough neck coil, you might have to put a flex coil across their top of their chest to get good signal from the top. Has anybody done that where they don't really have a anterior neck coil, but they use a flex coil? Have y'all seen that before? Sometimes you do that, especially with bigger patients that don't fit into the neck coil that attaches. You have to put some kind of anterior coil, and they use the abdominal flex coil for that. So for soft tissue neck, not only the anterior, but we also want to attach the brain coil. So So it says center at mid-neck, so think, just like with x-ray, C4 would be a good area for that, right on that thyroid cartilage there. And here is our Emory protocol for our soft tissue neck. Here's one without contrast, here's one with contrast. So with our sagittal, with our field of view, we want to get top of the sella. So where's our sella sit? What's the gland that sits in the sella? Pituitary gland. So think almost like midbrain, all the way down to the thoracic inlet. So you can see here how much area we're covering. That's why it takes so long for these particular exams. And then we have protocols for different types of tumor. Thyroid, carotid gland, oral cavity. So make sure you're selecting the appropriate protocol. I know they already protocol everything, but make sure you're reading the order and everything's matching up. Have you guys had to change an order where it was protocoled something and then you saw the actual written order, it didn't quite match up? Have you ever had to do that?
Yeah.
Yeah, it happens, right? You know, these are residents reading the order. Sometimes things don't get communicated appropriately, so you still need to read. Don't just go, oh, H3, hey, you know, I'm just going to run it. Always check the order. All right, so our localizer exam, remember we're centering at mid-neck around C4. So you're getting from the sella all the way down to the thoracic inlet. Some people also say at least to the clavicles. So you can see, if you can see the aortic arch, you're doing good. So your axials are going to be perpendicular to your spinal cord. Larger field of view to get the entire, because you can see here how it gets the entire neck and head, but then things start to really widen out once you get to the shoulders. So make sure you're using enough phase oversampling depending on what your phase direction is. Your sagittal, we already talked about this. They want to make sure you cover from the sella all the way down to the thoracic inlet. Here's that aortic arch. It's black because this is a black blood imaging, so it's a spin echo pulse sequence. So all our blood is going to appear black. That could be one of the branches off the aortic arch there. So you need to get from skin to skin, basically, on your sagittal. Your phase oversampling is A to P, so you don't have to really worry about anything wrapping into your image. But sometimes you want to have that oversampling here to reduce the arteries, that phase ghosting artery artifact coming up from the carotids, or that swallowing artifact. Because we can't put that spatial saturation band inside the field of view this time because they're looking at these structures. We can't just cover up those arteries with that sat band. And then coronal, you can see basically from the tip of the nose and covering all the way back to your spinous process. So when you get posterior to the spinal canal. And see here how our phase oversampling is pretty large, right to left, because we need to worry about those shoulders once we get down here wrapping into our image. So we don't want those shoulders to wrap in, so that's why we need that phase oversampling out here. Remember, the arrow always indicates our phase direction. MRA of the neck. What's MRA stand for again? MR angiography. So bright blood imaging, these are gradient echo pulse sequences. We're using contrast as long as they're not allergic to contrast. If they are allergic, what kind of time of flight are we using for MRA? 2D, larger area of coverage. So here are some of the indications. Arterial dissection, arterial venous malformation. If it's in the brain, the PC MRA was the best option there. But if it's in the neck, we're using time of flight or contrast enhanced. Any injuries to the arteries, aneurysm, outpouching, tumors, vertebro-basilar syndrome. Same coil, same positioning, same centering point. Usually this MRA of the neck is associated with what two other scans? if we have a stroke protocol, what are the 3 scans that we do? Stroke protocol, we do 3 scans.
Brain.
A brain, MRI of the brain.
brain, yeah.
What else? MRA of the neck and MRA of the what? We got the neck, we got an MRI of the brain, but we do an MRA of the brain. So time of flight of the brain, the normal axial slices for the MRI of the brain, and then MRA of the neck. Stroke protocol, MRA neck, MRA brain, MRI brain. So that's where you you bring all 3 of them over, you make sure you do all the pre-contrast images, you inject, you get the neck, then you get the brain. So it's really important to make sure all your pulse sequences are arranged appropriately. A lot of times I always did the time of flight of the head first, the MRA of the head first, after my sagittal localizer or my sagittal, just in general. And then while the brain is scanning, I cut out or segmented my anterior and posterior circle of Willis, so that right as I was injecting for the MRA, the neck, I can time that appropriately, and all I had to do after the patient was taken off the table and to do post-processing was just cutting out the carotids. So that's the most efficient way to do it. Time of flight, MRA head, MRI brain pre-contrast, MRA neck, MRI brain post-contrast. So that would be a good order to do those things. But everybody does it different, so just follow whatever tech you're working with, but I found that to be the most efficient way to do our stroke protocol. Make sure that everything goes under the appropriate session number. That's a big thing with the MRI doctors now, is making sure the right images go under the right folder. So here are our protocols. This is the without, so you can see here it's a 2D time of flight. This is with and without. We still get our 2D time of flight, but then we get our MRA pre and post. Remember, if we have an MRI pre and post, that's where we are subtracting to get rid of that stationary tissue. And then you still need to do the MIPPing. So here it tells you which type of MIPS you need. And then this is the dissection protocol. So the only difference here is we're adding that T1 fat satin through those carotid arteries. Localizer scan looks the same. Here's our 2D time of flight, and this is kind of what it looks like. You get good morphology of the vessels, but not as good of morphology as a contrast enhance. We use that to set up not only our 2D time of flight, but our contrast enhance for our 3D time of flight. Remember, if it's 3D, typically it's just going to be covering that bifurcation. And where does that bifurcation happen?
C4.
C4, C5. Good. Here's that T1 fat set. So you can see here, we need to get the aortic arch. We need to cover from the aortic arch all the way up to where it's almost going into the basilar artery. So going all the way up to almost the IAC's pituitary gland area. So a lot of coverage. We need to time this appropriately. So once we inject, how long do you think does it take to get from antecubital all the way up to the carotids? How long? What? Give me like a second. 2 seconds too early. 15 right at the end of it, but 10 is kind of the number you're going for. 10 seconds from going in the arm, going in the heart, up the aortic arch, boom. Once you see it hit that aortic arch, we start our pulse sequence. Because we don't want to see that contrast going into the carotids. We want to see it barely touching those carotids, and so you can time it appropriately. If you don't, you get this, what's called venous contamination, where it's not only gone up the arteries, but now it's gone in the brain, and now it's coming back down through the jugular vein. So those are the jugular veins that are contaminating what you need to see. All right. So the major protocol that has been of wide discussion is our brachial plexus, but these are our indications. So we already talked about a couple of these. Weakness on one side, upper extremity, neuroma, schwannoma. Where else did we see a schwannoma? What area did we see a schwannoma? Brain, but what particular protocol do we need to do when we see vestibular schwannoma?
The EAM.
EAM or IACs, yeah. So a neuroma schwannoma can occur anywhere where you have nerves, because remember you have your cranial nerves, and cranial nerves 7 and 8, vestibular, cochlear, and facial nerves run through the IACs. But anytime you have a nerve, you could get a neuroma or schwannoma. So that's another indication. Neuropathy, what does neuropathy mean? It's just any type of pathology associated with the nerves. It could be pain, it could be numbness. Neck injury, like there could be like you could get in a car accident, and for some reason you have, an issue with your brachial plexus. Radiation plexitis, so you can get inflammation from the radiation. If there is a tumor and they've been irradiating it with therapy, you could get inflammation. So sometimes we do, after they've gone to radiation therapy, we do an MRI. Things like that. Thoracic outlet syndrome, we already covered that. Positioning of the coils, pretty much the same. We're going to be centering a little bit lower because we need to get down to the shoulders. We're not as concerned with the neck because the brachial plexus nerves start at C4 and C5. We don't actually get all the way up to C1, C2, and C3. So we've got to be a little bit lower. Here is the non-updated Emory protocol. You can see here. But then here is the most recent. It's a little hard to see, so I'll enlarge it. But we have several indications. So we have, this is our standard protocol. This is one where suspected thoracic outlet. Remember, thoracic outlets, that's where your nerves and those vessels are all being compressed. And then we have one where it's tumor versus radiation. And it could be radiation plexitis. So you can see here, it's mostly, these are going to be done on 3 Tesla because we need that higher signal, higher resolution. And most of the sequences are going to be very thin slices or a 3D acquisition. That's what the space is for. That's a 3D acquisition. Sometimes they're going to have their arms up, sometimes they're going to have their arms down. Some sequences you're going to do bilateral, some sequences you're going to do unilateral. So just pay attention to all the different pulse sequences that you need. And like Tyler said, this is one where you're typically going to be watching, but if you have seen a couple, they might let you get your hands on a brachial plexus. But you're going to be constantly in contact with the MSK docs to see if you have all the pulse sequences appropriate. So you can see here with the axials, we got C2, 3, 4. So remember, the brachial plexus nerves start around C4, C5. So we don't need to get all of the neck anymore, but we need to get all the way down to T4 because those nerves go all the way down to T1, T2, and then remember they branch out all the way to the shoulder. Sagittal, they could be bilateral or unilateral, but most of the time the sagittals are going to be unilateral, so whatever the affected side is. But we always want to get a coronal bilat for comparison reasons. Because if they see the tumor on one side, they want to be able to compare what it looks like on the normal side. You can see here with the coronals, we're angling with the spinal canal because that's where these nerve roots are branching off of. All right, and last but not least, our indication for lumbar sacral plexus. You can see here leg pain. There's several different types. You got pain going to the calf, pain going to the femur, sciatic pain, which goes all radiates down the entire leg. Sacrum coccyx pain could be, but mostly it's going to be that sciatic. This is the one where anytime we do an L-spine, we have the luxury of doing it feet first for those claustrophobic patients. You're going to want to center a little bit lower than where we do for L-spine. L-spine, we're at the crest, just like when we do an L-spine with X-ray. Here we're going to want to be centered a little bit lower because we're kind of more concerned with that L5 sacrum region.
So centered below the iliac crest.
Yeah. So it says iliac crest, but I recommend going a little bit lower. But most of the time you're going to have two coils and you'll get all that area, but let's say below here. This is just an update. Good catch. All right, so here's our old protocol, but here's our updated one. So here we have a high and a low lumbar plexus. If you have a low lumbar plexus, you're really just concerned with the lower nerves coming from the lumbar, and that's really dealing with the sciatica. But if you have nerve issues coming from L1, L2, we do a high lumbar plexus protocol. And with the high lumbar plexus, you get a high and a low, so it could be even a longer exam. If the patient has a hip replacement, you do not do any of these, because that hip replacement and that metal is going to cause too much of an artifact to see any of these nerves. So just really be mindful of this last line right here. It says do not do if they have a hip replacement. Because that metal artifact is going to get in the way of those nerves coming down the leg. So here's our localizer. Here they did center it at the crest, but once again, you want to get a little bit lower because you're kind of more interested in this area. But if it is a high lumbar plexus, you still need to get L1, L2. Axials, you can see it's going out to the hip. So a lot of coverage, a lot more than our L-spine, where we're just covering the spinal canal. Sagittal, see here how we're getting all the way out to the femoral head. We're not just getting the spinal canal where we almost skin the vertebral bodies there. A lot of 3D acquisitions for this because we need really high resolution to see these nerve roots and these nerves. All right, so some common pathologies that you'll see on the test and on the registry. So we talked about vocal cord paralysis, parotid tumor, neoplasm with the tongue, with thoracic outlet, aneurysm, sciatica. So let's take a look at what these look like. So here's brachial plexopathy. So these damaged nerves result in pain, decreased movement, decreased sensation in the arm. So this is inflammation within that nerve right here. And this is kind of the most common area where it happens, where they all start to converge. You can see all the brachial plexus nerves up here coming from each vertebrae, but then they really start to converge here, right where you have that thoracic outlet. Vocal cord paralysis. Here is a fully functioning vocal cord where they both open and close, but then this one on the patient's left side is not closing up appropriately. Parotid tumor. So you can see that tumor on the right side here. So you can see these in the salivary glands. It says most of these tumors are benign, not cancerous. So you'd be below the jawline. That's where you're going to be looking for those carotid tumors. Tongue neoplasm. So we got the tongue here, that's soft tissue. You can see a little bit of different signal intensities within that tongue. Post-contrast, it lights up. Some risk factors include tobacco use, heavy alcohol, HPV infection. Arterial dissection. Remember on that dissection protocol, we needed the T1 fat sat, so that's the T1 fat sat here. And you can see that carotid artery, or in this case, I think it's associated with this vertebral artery back here. This is the vertebral artery on the left side that is showing the dissection right here. It splits the vessel in half. Aneurysm, you guys have seen this throughout the body, pouching. Here you can see the aneurysm on the external left common carotid. Here's that neuroma or schwannoma of the brachial plexus. So these are benign tumors of the nerve sheath. But even though it's benign, it could be compressing on a lot of other structures in that area, causing pain or some type of weakness and numbness. Thoracic outlet syndrome, this is where the blood vessels and nerves between the collarbone and your first rib are compressed. So you can see here on the right side of the patient how this area is a lot more compressed. Parsonage-Turner syndrome. So this is also called as brachial neuritis, so inflammation of the brachial plexus. You might have some decrease in muscle mass in that area. But you can see here how this goes all the way out. We have inflammation of, what muscle is this on top of the shoulder? This is usually what we set our slices up off of. On top of the shoulder. Supraspinatus muscle. So we have inflammation of the supraspinatus muscle there. And then sciatica. And most of the time that comes from that HNP, herniated nucleus pulposus, of that L5-S1 area. Compresses that nerve coming off of the L spine. Causes numbness and pain tingling down the leg. Treatments include self-care, medication, anti-inflammatories, muscle relaxants, physical therapy, but rarely it's done through surgery. Usually you want to do a lot of PT before you actually have surgery, any type of laminectomy or spinal fusion, anything like that. All right, so that covers procedures. You guys got any questions? All right.